Good morning, everybody. A very happy Doctor's Day to all of you, including my opponent, Dr. Rajiv Kovil, to you also. Yeah. But for some time, although we all protest the attack on doctors, but my dear friend, for a few minutes you might have to face some verbal attacks here and there. Please bear in mind, and I would give you a hug at the end of it. There is no conflict of interest for this particular debate. We are going to take you through this particular agenda of HbA1c, how and where it is, why these guidelines come, and there are how many guidelines, why this conflict of this storming session, which Dr. Neeta Madam just said, who's responsible for those issues like hypoglycemia, and for whom are we doing garden variety like patients? I think the organizers have put this topic very aptly. Most patients versus many. Now, literature-wise, most is taken usually in a positive form. Most people agree, most people survived, but many, what Dr. Rajiv is going to talk, many is usually taken in a negative sense, like many died, many people fell. So most of the time, Dr. Neeta is busy with the patients, but many patients of Dr. Sanjay Agarwal irritate him with some of the other queries. So that's the impact of understanding the first language of the basis of the topic. What's the life expectancy between these two doctors, where most of the time she likes to see the patient, and many of his patients are like this. It's a battle also between micro versus macro versus both. Let us look into what's the morbidity and mortality. Intensive drug treatment, we agree by now that for certain patients with comorbidities, it can do definitely more harm than good. And that's why we say that diabetes is just not a glycemic number. It's just not a glycemic happiness. It is much more beyond the happiness of a person, that you take into consideration his behavioral issues, his lifestyle issues, his blood pressure, his lipid issues, and his weight, of course. So when you look at all these things, I think we need to get and boil down to one particular thing, that although there is a little argument that the tight glycemic control lowers the risk of microvascular, what about others like the cardiovascular or the macrovascular or the metabolic vascular issues which need to come? So here we are not talking only about just reduction in mortality with some drugs which came in the last 3 years. We are looking at reduction in mortality as a whole. We are looking at cardiac mortality. We are looking at other things, including hypoglycemia, where we look into this. And what is the question? Hypoglycemia, the weight gain, fluid retention, the elephant in the room, increased cost, and the death. So these were some slides on ACCORD and ADVANCE. I would show you directly some main slides talking about that why there were no benefits. Although these were the yesteryear trials which formed the basis of the HbA1c recommendations today, but my dear friends, it was the iceberg which was so large down the ocean of hypoglycemia, where because of which the benefits were not seen. And if you see the all-cause mortality, it was definitely more for the patients where survival was less, where most of the diabetes control was bad throughout their 10 to 15 years before randomization and selection. So the benefit in such levels from the glycemic control is modest compared to control of lipid and blood pressure, and that is why we say don't just look at glucose as a number, but look at other risk factors also. There are two important things about HbA1c. One is all-cause mortality, where the slide is here, and my dear friends, there are two papers, one in NEJM, which came around 5 years back, and one in JCEM, which is one of the highest standards of endocrine and diabetes journal, which just came this first half of this year. It says that even at just not at higher HbA1c, but also that lower HbA1c, you get mortality and a lot of hypoglycemia. So we got to really find a path where we give the patient a quality of life. So when Dr. Neeta sees most of his patients, they say, Doctor, humko zindagi jeena hai, umar nahi kaatna hai. So we don't want to die. Jannat sabko jana hai, but marna kisi ko nahi hai. So that's the reality of life. We all want to live life to the fullest extent. So this is what is about all-cause mortality and how we extend this into the guideline or the guidance given by the American College of Physicians, which targeted the audience as all clinicians. Patients were around type 2 diabetes, and they came out with few sentences talking about this last 4, which I'm going to talk to you in my few slides. So the guidance one which came, clinicians should personalize goals for glycemic control in patients with type 2 diabetes. The debate is about most patients with HbA1c with ACP. ADA also says individualized therapy, right? Individualized goals. ये तो personalized बोल रहा है. On the basis of a discussion of benefits and harms of pharmacotherapy, patient preference, patient's general health and life expectancy, which is so very important when we try to robustly add our pharmaceutical pluralism suddenly into a patient's prescription. Treatment burden, cost of care, and hypoglycemia. And the rationale was that all the guidelines recommend personalizing HbA1c goals for individual patients. This is what ADA also is saying. The choice of glycemic target also depends on consideration of other variables, which is very important when we write a new prescription for any patient, even at the time of their follow-up. Risk of hypoglycemia, weight gain, and other drug-related adverse effects, as well as, again, the age and expectancy of the patient with functional and cognitive impairment. Now, from a younger generation, in another 10 to 20 years, India would be becoming a more middle-aged and moving more towards a geriatric population as per 2018 consensus and population guidelines. The statement 2, which the ACP says, clinicians should aim to achieve an A1C between 7 to 8. Again, here the word is in most patients with type 2 diabetes. Now, what is the meaning of this? Most is what we need to understand to put this line into perspective. Most here means jinka zindagi is around less than 10 years left, where the patients have life expectancy which is less, where they have a lot of morbidity already, where they have had a long-standing uncontrolled diabetes, and where we need to give them a quality of life rather than just getting their HbA1c down. Now here we are not including patients where we take down their HbA1c down to diabetes reversal. Now that's the difference in understanding this particular statement. Yes, we have the highest number of patients of diabetes reversal in Mumbai, but also to be looked into, this is another aspect that we talk about. I can hear Rajiv already influencing my chairpersons and the organizers. He shifted his place already. So that is called as most people would agree upon. Thank you, Rajiv, for that move. Yeah, just to add, he also had some water at the back. Statement 3. Clinicians should consider de-intensifying pharmacological treatment in patients with type 2 who achieve less than 6.5. Again, to give them the most of the benefit, we need to de-intensify therapy, but the tagline here is, my chairperson, please note, the tagline is, it should be the lifestyle modification which should drive the reduction of HbA1c beyond a certain point, and not the drugs if you're taking the patient to diabetes reversal or a tighter control, or if the patient is young and the patient is healthy and the patient agrees for an aggressive control. This is what is the meaning of this particular statement, that why we need to de-intensify, and this is where we say that discontinue in some where the A1Cs have fallen to less than 6.5 to less than 5.7, almost into a normal glycemia. The guidance statement 4 of ACP, clinicians should treat patients with type 2 diabetes to minimize the hyperglycemic symptoms, avoid targeting HbA1c of patients with less than 10 years, which is what we all are already doing. That's where ADA says individualized therapy. That's why when we read these two papers, I think it's the perspective, that's the word that needs to be taken into consideration. Due to advanced age, whether 80 years or more, maybe for India we can take 70 years or more, residents in a nursing home where they need a help to live their daily issues, chronic conditions like dementia, cancer, end-stage kidney disease, or severe chronic obstructive pulmonary disease or congestive heart failure, because the harms are definitely outweighing the benefits in this population, and that is where the guidance for came in this particular way. So the rationale here was exactly what we just discussed, and here I would want to say that there is yet to be more scientific evidence to get HbA1c below 7 to improve, concentrate on the second part, to improve micro and macro without causing or without decreasing the quality of life, without causing a dementia, without causing a hypoglycemia, and then only we will be doing the premium non-nocere. I think I would rest my case over here, and I'm much before time. Over to chairperson.